Well, I'm impressed that I'm following a baroness. That's quite a distinction for an Iowa farm girl. So thank you for the invitation and greetings from my colleagues at the Institute for Healthcare Improvement. They say, oh, you get to go work with those cool Canadians. We've had numbers of opportunities to work together as shared interest in our North American challenges that we all work towards. So thanks for inviting me here. And particularly for a topic that I am incredibly passionate about. I think it dates back to my days as a labor and delivery nurse and the work that I did there and learning about what it takes to really be with a family when they're welcoming that new child into this world. What I was asked to, and I love the topic of making sense of patient and family partnerships. And when I think about making sense of something, and I can make things pretty complicated, I like to distill it to its essence. What are we really talking about here? And as we look at that essence, what does that mean for us as we try to make sense of what is really a very, very complicated topic? And so I'll offer you my thoughts of what I think is the essence of partnering with patients and families. And in that, hopefully simplifying doesn't mean simplistic, but really it's simple, not easy, as I and others work internationally to improve the patient experience. So I'm thrilled that you here in this province have such a strong interest in it. I'm just thrilled. And how I make sense of it is really thinking of it as a journey of where we've been as healthcare professionals. So really, how I think of it is where I stand. So grew up in Iowa, have been a nurse my entire career, healthcare executive, all in the U.S., so I take a very U.S. perspective, so discard what doesn't apply. And I think about where we've been in thinking about partnerships with patients and families. Bit of overgeneralization, but trying to highlight the characteristics. So I think of it in terms of 3 stages of our journey. The 4th, yet to be described or created. I think you in this province will help create that next or 4th phase of the journey. The first part of it is doing to, second is doing for, third is doing with our partnerships with patients and families. So if I think about doing to, it's characterized by, and when I say I, that's from a healthcare provider or clinician standpoint, and you as a patient or consumer. I talk, you listen, then you act. And we fix you. We fix it for you. So it's characterized by language like compliance. Although in the U.S. we've gotten a little bit better, we refer to it as adherence. We don't call it compliance anymore. We think we've made progress. It's characterized by hospitals as really elegant prisons. We tell you when to sleep, when to eat, what to wear, what time we will do things, and you do it agreeably. Otherwise, you feel at risk that we'll punish you. It's characterized by families being viewed as visitors, not co-creators of health and healing. There's very rarely openness or transparency, and as a matter of fact, in my career, it's also been characterized by lies. And I don't like to think that in my career I lied, but when I think about perhaps withholding information, not sharing a full story for the benefit of me or my organization, that fits the definition of lying, which is communication with the intent to deceive. And we do have a few seats up here. I know it's a bit like going to your faith community. There are a few seats up here. We have waste-filled organizations, but we don't even recognize the waste that's there. And the waste comes forward in many ways. Waste of precious time of patients, families, staff, and physicians. We use terms like known complication of care. So if you have a ventilator, we assume that you would have pneumonia. If you had a catheter, we assumed you would get infected. We now know those are false assumptions. But that's where we didn't even see the waste that it was around us. It was so part of our environment. Some of the other examples that I have from that in my early career, fathers, partners weren't allowed in the delivery room. And when I asked about that, I just had questions because you need to know, I come from a very large, very vocal, outspoken Irish family, where women are similar to what you hear about from Prairie Home Companion and Garrison Keillor. I don't know if you, kind of like what they describe in Minnesota, where the women are strong, the men are handsome, and all the children are above average. Well, the women in my family were strong. And I had two aunts, Eileen and Maureen, and they were labor and delivery nurses, and they would regale me as a young person with getting fathers into the delivery room. This was in the 1950s and 1960s, when that was unheard of. So I grew up kind of thinking, well, that's what good, strong nurses did. Imagine my surprise at the University of Iowa when they didn't welcome that suggestion from a brand new graduate nurse. And when I asked why, again in my outspoken way, they said, well, they might contaminate the sterile field. All right, call me crazy, but I thought that was a dumb excuse. Thought it was dumb then, it was dumb. But we had examples like that. We didn't tell people their diagnosis of cancer for fear that they would give up hope. My pharmacy colleagues said that we would not put the name of a medication on a prescription bottle because some physicians didn't want their patients thought they would worry or it would confuse them. When I went to Children's as a VP of patient care, this was even in the 80s, we were just getting over the notion that children didn't experience pain the same way adults did. So we undertreated children for pain. I don't know about you in this country, but we just recently started giving newborn babies some anesthetic when we did a circumcision. Why we do them at all is another conversation, but we won't go there. So doing two has been a very dominant part of how many of us as health professionals and health leaders have been indoctrinated. It was also fed by our weird structure of when you're a healthcare executive, you're over here and the clinicians are over here. So in our country, you do the business model, you do the marketing, you do the promotion, and the clinicians take care of everything else. They're separate. So often, even to this day, you will talk to colleagues of mine, and I've been a hospital and clinic CEO, who don't believe that clinical care is part of their scope. My colleague, a dear, dear colleague, very talented guy, who succeeded me in my role as CEO in our health system when I took on quality and safety for the entire system. When I was coaching him, and he asked for coaching about taking over this new role, and he was general counsel. He was our head lawyer in the organization. He said, well, I don't know, Barbara, you're talking about a lot of clinical stuff. You know, I'm an attorney. I don't know this clinical stuff. And I said, Mark, shut up, get over it. You're heading a clinical enterprise. That is your work. That's my approach to coaching for those of you. So I said, this is your job. So now you have a learning curve. And you've done that kind of translation for a long time of being an attorney and helping me with a clinical background to understand how we need to approach things. So look at that differently. A few more things that characterize doing two is that information is rarely shared in the presence of a patient. Nurses at the change of shift, I don't know how they do it in Canadian hospitals, but in the US, we loved our conference rooms. We'd go there and we'd have our change of shift report where all nurses would disappear for roughly a half an hour, stranding patients, abandoning them. Well, a number of years ago, somebody had the novel idea of saying, it's patients' information, how about we do that with them at the bedside? You cannot imagine the angst, or maybe some of you can, of some of the nurses in going through that major cultural change. I'm finding our younger colleagues who are used to posting information on Facebook are much more comfortable with, it's their information, for goodness sakes. It's some of the colleagues who have been at it a little bit longer. And if we do share information with patients in this doing two phase, we often use terms that you cannot possibly understand. Our concept of health literacy is non-existent. And often it's characterized by helplessness. I don't know who's in charge of my care. I don't know what's going to happen next. And I don't feel as if you really know me. That's in our doing two phase, and I think most of us now recognize that's not conducive for anyone. It's not great to be a caregiver or a leader in that kind of situation. Now, and I use the term caregiver broadly here, whether it's a family caregiver or me as a nurse or respiratory care practitioner, all of those roles. However, we still see glimmers of it, sometimes more than glimmers, bright spotlights of it, because that's the way we've done it. It's our practice. It's how we were recognized and developed. And the faster we change those settings and those new practitioners who come into those settings to a different way. And what I'm seeing is very good and very encouraging in my work with hospitals, clinics, and providers across many, many settings as we move in that journey to doing 4. It's very different than doing 2. In doing 4, it's characterized by me saying, I plan, and then ask, so what'd you think about that? We put it together. What'd you think about that? Whereas in the primary stage, that first stage of doing 2, we wouldn't have even acknowledged that. And the intent is we help you. It's often characterized by terminology like patient satisfaction or service excellence, so that awareness that that's important. In the doing 2 phase, it's rarely even acknowledged that that's important. Avoiding complaints and avoiding lawsuits, at least in the US, might be a motivation. But certainly it isn't a motivation because it's an important and inherent part of how we do care. It's still often in this stage is separate from the quality and safety of care. So it's something over here. I warned them I'm a mover, so I'm a little knocking things here. But it's often seen as separate from quality and safety of care. We're getting over in this stage that it's a nice thing to do, something we'll do when we get around to it. But it really is an awakening of this is what it means for us to do for one another. It's still dominated by institution, organizational, or professional perspective. So we're doing 4 maybe in a kinder and gentler way, but it's still who's in charge. The who's in charge is usually professions or organizations. Family presence is emerging as an important thing. There's a recognition that families are important team members in the journey to health and healing. There's emergent transparency. There's a recognition that withholding information is not only wrong, but usually harmful to all involved. So a wonderful growing recognition there. However, in the US, we still have major battles with our legal colleagues who get nervous that we'll get sued. And my career, I've had the unfortunate experience to know that if you aren't transparent, you will get sued in our country. And that's appropriate. We're waste-filled, and we're recognizing that our systems are waste-filled, but we're missing a couple of things. One is the waste if we don't involve patients and families. That waste of knowledge, of skills, of beliefs that they bring to the partnership that is conducive, that is essential to health and healing. We also don't recognize some of the inherent waste. I don't know, how many, if you're in an institutional setting, either a clinic or a hospital, I asked this question of my colleagues in the US, how many square feet are dedicated to waiting? In many organizations, it's one of our largest single dedicated space. It's so much of what we do in our organization, we don't even step back and say, have we ever counted all those square feet? Then that presumes somebody sitting there waiting. So we don't even count the hours of the people who are sitting in the seats in the square footage we built. It's characterized by still our retention of arrogance. And I've never felt that I was an arrogant person as a healthcare provider. I'm a good, kind, caring person. But as long as I hold the sense that I have the information and I'm doing good by inviting you into it, is a form of arrogance. An example that a colleague gave of doing 4 This is Chris White from Spectrum Health in Michigan, and they're doing some phenomenal work there. And in their children's hospital, which, by the way, just won a major award from the National Patient Safety Foundation in the U.S. for their work there, they had a group who is very interested in making things better for parents in the pediatric ICU. And so this group, which did not include parents, by the way, this was early in their doing for stage, decided that it was tough for parents to get out in the morning to get even a little bit of breakfast. So let's have someone go around, a volunteer perhaps, and offer them muffins and coffee. And so they put that together. Did that for a couple of years. Then they moved on, and I'll speak to that in a minute, in their progress to doing with. They have very active partnerships. They have over 100 patient and family advisors on every key committee in their organization. They do not do anything without partnering with patients and families. And they started talking about what parents were interested in, what were most important for them in the pediatric ICU. And the parents said, you know, that muffin and coffee, that's nice. That's nice. We just want to know who's in charge of our child's care. So you go, okay, muffins and coffee, or who's in charge of my child's care. You start seeing there's a different definition of what's important there. So in essence, they said, keep your muffins and coffee. If we know who's in charge and when they're going to show up, we can go get our own muffins and coffee. All right? So the wisdom of those we are dedicated to working with and serving is where we get our answers.